So next, pregnancy complication, cardiac disease. Remember that we talked about normal in pregnancy is a blood volume increase up to 50%. So if mom has a healthy heart, it handles that increase in blood volume quite well. However, if mom has cardiac problems prior to the pregnancy, then that increase in blood volume can cause problems. Assessment-wise, you might ask level of exercise that's tolerated, if there's any cough or any edema, obtain baseline vital signs, palpate liver size, and maybe do a EKG. Fetal assessment, we're going to encourage biophysical profiles to monitor the baby's well-being and to help monitor growth. Education, we're going to promote rest. We don't want this mom's heart to be under any extra stress. If so, then it may cause further complications. Promote healthy nutrition. You're going to educate them if they're on any medications, and then educate them also in regards to infection. They're at increased risk for infection of their cardiac valves. Nursing interventions during labor and birth, mainly think of ways to decrease the stress on the heart. So labor is painful, so if mom's in a lot of pain, her heart rate will go up, which will cause further complications if she has cardiac disease. So these women, we're going to encourage comfort techniques, epidural anesthesia, continuous monitoring of fetal heart rate to make sure the baby's doing okay, take frequent vital signs. Postpartum-wise, we're going to monitor for heart failure because when we talk about postpartum, we'll talk about that increase in blood volume in pregnancy and how that returns to baseline during the postpartum period. And if mom has cardiac disease, this can be hard for her heart to adapt. Also assess the baby for complications for mom's cardiac disease post-delivery. Hematological disorders, iron deficiency anemia is quite common in pregnancy, and then we'll briefly talk about isoimmunization here. Iron deficiency anemia is defined as a hemoglobin less than 11. We encourage iron supplementation and diets high in iron-rich foods. The women will tend to tire easily. They're at increased risk for infection, increased risk for pregnancy-induced hypertension, bleeding. Their healing will be delayed. Iron deficiency anemia, if you're giving an iron supplement, you want to educate the mom on what to do when she takes that. So such as take with orange juice, not milk, take on an empty stomach, not a full stomach. It can cause constipation. Do not report black stools. That's a normal finding while taking iron. Isoimmunization, so up to about 18% of pregnancies are affected by this. It's when an Rh negative mother carries a fetus with Rh positive blood. In utero, there's really no way to test baby's blood unless we do an invasive procedure. So we treat mom as if she's Rh negative, we treat mom as if she does have an Rh positive baby in utero. We don't actually test it until after delivery. So in utero, we give RhoGAM at 28 weeks. And if any traumatic event occurs that could cross fetus and mom's blood, so amniocentesis, car wreck, miscarriage. Otherwise, we just routinely give RhoGAM at 28 weeks of pregnancy if mom's Rh negative. After delivery, if mom's Rh negative, we test the baby's blood. If baby is Rh positive, then we give another dose of RhoGAM within 72 hours of birth. If mom's Rh negative and baby's Rh positive, they could be at increased risk for hyperbilirubinemia, which we'll talk about when we talk about newborns. They become jaundiced more easy. Their immature livers have a hard time breaking down the excess of red blood cells. Here's a picture of Rh negative mothers, and if the blood crosses and actually developing antibodies. So if an Rh negative mom has an Rh positive fetus and that blood crosses over, then she can build up antibodies to the Rh positive blood, and in future pregnancies can attack a fetus if it has Rh positive blood, because her blood has developed antibodies against that fetus. So it usually happens with subsequent pregnancies, not the current one. GBS infection, which stands for group beta strep. It is a infection that any of us females can have in the vaginal region or rectal region. And if we're not pregnant, it doesn't bother us. We never know it's positive. It comes and goes. We're fine with it. However, if you're group beta strep positive in pregnancy, it can be harmful to the baby, and it can actually cause preterm labor in the mother. So we want to know if mom is group beta strep positive if she goes into labor. So we test her close to the end of her pregnancy. So routinely we swab women around 35 to 37 weeks of pregnancy. It's a swab that's vaginal and rectal, sent to the laboratory. If mom is group beta strep positive in that routine screening, then we will routinely treat her while in labor with IV antibiotics to try to prevent the baby from getting the group beta strep infection, which they can become septic with, and it can be fatal. If mom has not been tested, so she comes into the labor and delivery unit and we do not know her group beta strep results, then we can swab her and send it, but we're not going to have the results back. So we tend to routinely treat women that are preterm, because the actual group beta strep infection can be the cause of her preterm labor. If she is preterm, we talked about if she has membranes that have been ruptured greater than 18 hours, we will routinely treat her. If she has a temperature greater than 100.4, or if any point during her pregnancy she showed GBS in her urine. Premature rupture of membranes. So if mom is preterm and her membranes rupture, lose amniotic fluid, but prior to the rupture membranes, prior to 37 weeks and 6 days, this is associated with chorioamniotitis, which is an infection of the amniotic fluid, the complication being the infection itself. So management would be risk versus benefits. So do we deliver? If mom is running a fever, if she's grossly ruptured, which means the entire bag of waters is gone, then most of the time we'll go ahead and deliver. However, if it's just a leak and mom's WBC count and temperature is normal, then they may choose to monitor the mother instead of going ahead and delivering. So this being another reason why rupture of membranes is not a true sign of labor, because you don't necessarily always deliver, especially if it's just a leak in a preterm pregnancy. Adolescent pregnancies, they're at higher risk for complications: pregnancy-induced hypertension, anemia, preterm labor, cephalopelvic disproportion, postpartum hemorrhage, inability to adapt, and lack of knowledge. They have an immature reproductive system and tend to have poorer diets. This is a picture that kind of goes along with that. So if you think of their vessels being immature, their uterus being immature, then a lot of times it will cause a lot of the complications that adolescents have. Now on the flip side of that, a lot of times adolescents will have easier labors. Elderly pregnancy, so with a pregnant woman greater than the age of 35, it's now considered an elderly pregnancy. They're also at higher risk for complications: pregnancy-induced hypertension, failure to progress in labor, difficulty accepting the event. They're at increased risk for postpartum hemorrhage. Their reproductive system may become lazy because they've had their uterus and all of that stuff for 35 or more years and it's never had to work to have a child, and now all of a sudden has to, so it's not really, think of it as not an unconditioned uterus.